Hi, Ivana.
Hi.
Hi.
Okay,
I've got,
Pooja,
sorry,
yeah, Pooja will join now.
perfect. She was here, but I lost her. We've got Christian in the waiting room. Do you want me to let them in?
Yeah, just let whoever comes in, just let them in. Hi, Christian.
Hello, how are you?
I'm doing good, and you?
Yeah, good, thank you.
Okay. Yeah, we're just waiting for the other participants to join, and
no
Alison is the
worries.
moderator. So we still have a few more minutes, and I am still receiving emails. So I'm just going to deal with that, and I'll mute
Yeah,
myself for a moment.
No problem. Hello,
Hi, how are you?
I'm good, how are you?
I'm good, thank you.
Good. Are you speaking today at the roundtable?
Yeah, I'm the Chief Strategy Officer at Inspired Minds, so we're the organisers of it.
Oh, great, okay. I'm a bit early.
We'll be seeing you at IH UK Live, I suppose, in a month.
Yes, exactly. Yeah, exactly a month, isn't it? Yeah, looking forward to it.
Yeah, it'll be fab. We have a text. I'll just mute myself whilst we wait for everyone. Hi, Rizwan, welcome. How are you?
I'm all right, made it, thank you.
Good, good. We're just waiting for everyone else to join and then we can start. I'm Pooja, I'm the Chief Strategy Officer at Inspired Minds. So we're the organisers. So we're just here to facilitate, but we'll let everyone come on board and then Alison can share.
Sure, pleased to meet you.
Lovely to meet you as well. And we have Christian on as well.
Hi, Rizwan. Nice to meet you.
Hi, Rizwan.
Hi, Ivana. I made it.
Can you hear and see me?
I can indeed. Thank you.
Hi, Mark. Hi, Alexander.
Hello.
Hi.
Hello. Hi.
We're just waiting for all of the participants to join. Just as a quick intro, I am Pooja. I'm the Chief Strategy Officer at Inspired Minds. I have my colleague Ivana on the line as well. And we're just waiting for Alison and a few others. And we have Christian, Rizwan online as well. So feel free to go on mute or carry on with some stuff just whilst we wait for the others to join. Hi, Chris, welcome.
Hello. Sorry. Recapture login issues, ironically.
Cool. We are just waiting for Alison. I think she's just having some problems logging in. She'll be chairing the session today. So we have, I think, everyone else here. We have Christian, Rizwan, Alexander, Mark, and from our side, I'm Pooja, and I have Ivana from my team as well. So I think we should be good to go in just a few minutes as soon as Alison is able to log in. Okay, so I've just had a message. I think Alison is just having some issues logging in. So I think we can get started with the roundtable. So again, welcome to you all. We're here for a roundtable on generative AI. We're specifically looking at ChatGPT and the implications on healthcare. So it's brilliant to have you all on board. I know that we'll be meeting officially next month at Intelligent Health UK in person. Obviously, there is a lot going on around generative AI and especially the impact that it has on healthcare. So I think this is super timely, and what we're looking to do is sort of make sure that the conversations that are happening in the industry are captured, that the people are at the heart of using some of this technology, their views are heard and shared. So what would be great to start off with is perhaps if everyone can go around and do a quick introduction of who they are, a bit of background, and then also kind of initial thoughts on generative AI in healthcare as well. And perhaps, Christian, if we can start with you, that would be fantastic.
That's great. Thank you. Hi, everyone. Nice to meet you. My name's Christian. I'm a clinician based in Liverpool. I have interest in global public health, and I'm currently doing a master's at Keele in global healthcare leadership. And I also work in Alder Hey as a clinical fellow in innovation. So a lot of the work there is involved around bringing new technologies to patients and how we can kind of use those technologies to reduce healthcare inequalities. So I think, like everyone, I've been using ChatGPT for the past few weeks, and especially the ChatGPT 4. It's just interesting for me to see how rapid the pace is of development in this space. I think it does raise a lot of questions around, ethics, security, especially regulation in healthcare. How do we actually, take a proactive approach to bring these technologies into hospitals in a way that is safe and, accounts for the limitations of the current models as well, especially when you have, I'm sure everyone's experienced this, when you've queried the current GPT models and it's quite confidently give you a wrong answer. That's fine for us as the experts to kind of understand that, but how does the average person kind of interpret that, especially where there's limited access to technologies?
Brilliant, thank you, Christian. I think, yeah, there's definitely some food for thought there. Rizwan, can we have an intro from you and some background?
Hi, good morning, everyone. Rizwan Malik. I'm a radiologist who works in Bolton, the NHS, and I also have a consultancy firm dealing with predominantly imaging and AI companies, looking to establish use cases and how perhaps we can best leverage them to support health tech for the betterment of patient care in the UK.
Brilliant, thank you. And over to Mark.
Hi all, I'm Mark Farr, I'm Chief Analytical Officer at East Kent Hospitals, and I'm also the Chief Analytical Officer for the ICB across Kent and Medway. I've got an academic role locally, and I chair an AI working group for the region, which doesn't imply I know anything about AI, because I don't really. But interestingly, I just put into ChatGPT the questions that you wanted to ask, so I'll just reel those off at the right time, if that's something. I mean, a few points from me. I have a particular academic interest in inequalities, and I think touching on something Christian said, I think there's a really interesting, a huge area to kind of uncover. So I kind of worry about inequalities getting worse with AI generally, and the use of ChatGPT, whether it's a bot talking to someone to book an outpatient or a clinician making a guess at a diagnosis in conjunction with a patient who's already been on ChatGPT at home. ChatGPT in itself is, from what I understand, doing something that's actually quite simple. It's just doing it really quickly, and I think that's why people are kind of impressed by it at the moment. But what it's actually doing is not that clever. It's just doing it really, really fast. I suppose and the next comment for me would be the conditions for AI. So I work in a kind of provincial trust. It's not a big London teaching hospital. We don't have a huge research function. So I'm kind of interested in the conditions for use of AI. So we have partnered up with some London teaching hospitals to do the AI centre, and that works quite well because they have the kind of economies of scale around development and governance and all sorts of things. Ironically, we've moved much quicker than them because we can navigate some of those barriers more quickly because we've got fewer people to kind of get on side. So that's something I'm kind of really interested in. What are the conditions for this? In our AI group, we've created links with universities as well. I think, again, to Christian's point around ethics, I think it's really helpful because of potential bias and so on that we just keep the universities really close because there's some really interesting research around ethics at the moment. And I think the last point I would make, just as by way of introduction, is that the kind of where there's muck, there's brass is what I'm most interested in. I think the sexy AI stuff is sexy, but not really there yet. There's some interesting imaging stuff. We're looking at some nice open source tools like Total Segmentator and stuff, and it's all very sexy and visual. But I think the promise of this is actually at a much more mundane level in the first instance around things like data quality, clinical coding, use of SNOMED CT, recording conventions, aligning read codes and GPs with ICD-10 in hospitals. So really boring things, but I think it could be really helpful with solving some data quality problems. For me, that's my kind of initial interest. Thanks, Pooja.
Perfect, thank you. So it looks like inequality is kind of a recurring theme here. Alexander, over to you for a quick intro.
Hi, thank you. Alexander, registrar in East Anglia. Normally, I'm actually out of training program delivering a research trial and studying for a PhD in the Northeast. My trial is using an AI device to look for polyps in colonoscopy. Get my words out. There are numerous of these on the market, but obviously it's a very kind of frontline application of AI, and that's sort of what's got me into it. Some initial thoughts, really. I think that we all seem to be fairly confident that AI is going to revolutionize the nature of some, if not all, and certainly the delivery of all of healthcare. There is perhaps a danger of sort of AI being the answer, but what's the question? And particularly picking up on what Mark was saying about making sure that we get the basics right, you know, the kind of the really foundational stuff for for administrating and delivering healthcare is really important, as well as the stuff that actually kind of gathers the media attention and that people start to think about. Because AI can't really deliver healthcare on its own in order to actually make it that revolutionary sort of technology that we think it's going to be. It's all about how we partner as humans and as clinicians and you know, sort of CEOs and whoever else is using it, but how we partner with AI to actually make it work for the benefit of our patients.
Brilliant. Okay. Yeah, some good points there. I think we'll be able to pick some of those up in the discussion as well. Chris?
Hi folks, I'm Chris Callan. I'm a respiratory physician in Glasgow in the West of Scotland Innovation Hub. I'm one of the clinical leads there. We've got a range of projects. One is our eye care programme, which is setting foundations for digital radiology and pathology, and we've done various work within that ChatGPT's potentially got some close early applications to. But our main programme of work is around COPD, and we've started a trial using live AI for risk prediction scores. I can see lots of opportunity and potential early wins, some risks. And I think the inequality piece and the opportunity for these tools and the transformation to actually bridge divides rather than extend them is one of the things that we've got to do some work together to progress that rather than have the digital inequality become more of a chasm. But I think we can see a way. I think you've called out the opportunity, the possibility for these language models to be productivity hacks for us to improve some of the unstructured data, converting that to structured data, improving code and improving data quality. So even if the kind of the highest profile AI doesn't work out, then we'll have got various wins by bits of the cleanup and so on that we do to do the trialing of it as well. Plenty to talk about. I'll probably just stop there and let the discussions go rather than ramble on.
Fantastic. So I think that gives us a good background as to each of the participants here today. I think we've got a good breadth of sort of how it can be used. What I'm going to do is just give you some kind of overhead admin bits. As you have seen, the roundtable is being recorded. We're hoping to make it an on-demand piece for others in the healthcare industry to access as well once we've finished. And we'll also be writing a report on some of the key takeaways and ideas and thoughts that we share from here, which I'll write up as well. So if you see me typing away in the background, that's what it's for. If there is anything that you don't want to be quoted on in the report, just let me know. But what we'll do is, I think Ivana had circulated some initial points of discussion. So we'll go through those one by one. I think Alison is still having some issues connecting, so you'll have to bear with me as your moderator, if that's okay. So we'll go through those one by one, and what I'll do is I'll pick each of you to kind of give your comments on some of these, and please feel free to chip in where you think is necessary. If we feel that the discussion needs to go in a different direction to the points that we have placed on the initial agenda, that's completely fine. The key here is to really establish the implications, how we as a small group, and then turning into I guess larger group as well as we move into Intelligent Health UK, can identify and look to have some working solutions around ChatGPT, how we use it, the implications, the opportunities and the challenges. So hopefully we can start that discussion here today. So I suppose the initial point that we want to get into it is, what does ChatGPT even mean for healthcare? I know that's quite broad and generic, but I see that some of the introductions kind of touched on this, on things around inequality, you know, that maybe it can help streamline some of the admin work, that there are opportunities and roadblocks there. So it would be good to kind of understand, just as a generic starting point, what do we feel as a group that it means? So perhaps Mark, I'll start with you.
Yeah, sure. I mean, I was only half joking when I said I asked ChatGPT to give me the answer, but I then went off and was doing some reading last night, and there's a paper actually which has done exactly the same thing, which is to say to ChatGPT? What is the potential for ChatGPT in healthcare? And actually, that's vaguely sensible actually, because it gives you kind of the kind of big areas to divvy this stuff into, you know, so things like research, things like how you talk to patients, things like education, and things like telemedicine, and those seem perfectly sensible. They're what ChatGPT comes back with. There's within those specifically, we're doing some work, for example, on CogStack, and that is quite useful in the sense that it's putting some more papers out quite recently, actually, around the potential for using ChatGPT to diagnose as well, and comparing ChatGPT with things like Foresight as well. So that's kind of helpful. But those four kind of buckets of areas are helpful for us. For me specifically, I'll keep coming back to the two issues of inequalities and data quality, because they're the two kind of big things on my mind. And that's where I would kind of start with all of this. So I'm trying to, just at a practical level, trying to wrestle with getting, you know, a linked data set across a region, which could become the kind of pipeline for these secure data environments that we're all probably bidding for at the moment, and the local federated data platforms, trying to bring data together from different places. So what Christian might call COVID might be different to what Alexander calls COVID. You know, there'll be slight differences between each trust. Chris might define frailty slightly differently to me, and so on. And I think the automation of trying to align some of those things is where I'm kind of interested. There's within the data quality thing, and I will keep mentioning because I think it's important. There's a kind of continuum of the really simple stuff. Did we load about the same number of records last night compared to the night before? Did the columns that usually have letters in them or numbers or blanks? You know, that those types of things are relatively simple, through to what I was really impressed with ChatGPT was the way it could, if you take RTT, for example, the way it knew that maternity wasn't an RTT pathway, and was really confident of the background to knowing that. And you could then, in theory, encourage it to resolve data quality issues. So like, you know, have we got any people who identify as female who are aged over 100 who claim to be pregnant? And, you know, have we got any women on RTT pathways when that isn't an RTT pathway? So quite muck is brass data quality issues, I think you can kind of use it for. That's where we'll start, I think.
Perfect. And I see that we now have Alison on, so I'll just give her a quick welcome as we've started the discussions, Alison. Everyone's done a quick intro of who they are, so we've been through that, and we've just started on the first point of discussion of really what ChatGPT means for healthcare, and sort of, you know, what that means individually to all of the participants here. So Mark, there you just heard him kind of giving his view on that. So can I leave you to take the discussion forward from here? What I suggested was we all kind of give our opinion on that first point, and then we go through each of the points and kind of everyone can chip in. So over to you. I think you're on mute, by the way.
It's been one of those days. I apologise for my late arrival, difficulties with access for various computers. So thank you for that. I might as well jump to Alex then for your view on ChatGPT and its usefulness in healthcare.
Thank you, Alison. I think that following on from sort of my introduction, that ChatGPT could be used particularly in sort of two broad categories, and AI more generally, I suppose. But I like to think of it either doing things that humans can do, but doing them better, and doing things that humans can't do. There's a lot of scope in there, particularly as Mark was indicating, for trying to automate a lot of the grunt work, going and picking up on improving the quality, the thoroughness, the completeness of work that gets done that relies on humans, to do it, or indeed would rely on a human if there was a human available to do it. So I think actually kind of getting rid of a lot of the stuff that people don't like doing in healthcare is a really valuable use, because it can actually generate a whole load of insights that you would never ever really think of.
Can I just jump in as a non-clinician? So what tasks do people in healthcare not like doing?
So from a clinical point of view, they would tend to view it as more of the administrative work. But generally on the whole, you're looking at things that people don't feel delivers direct value to their patients or direct value to them. However, that doesn't necessarily mean that it's not delivering value. So again, coming back to Mark's example, if you've got really good quality sort of data around RTT or hospital episode statistics or anything, you could, taking HES, hospital episode statistics as an example, if you could use ChatGPT to investigate the quality of that data, and then perhaps even automate the way some of it is managed and processed, then you could be changing national level, if not international level data, and making our understanding of the health and illness of the population infinitely better than it is at the moment, because it currently relies on human coding, human transfer of data, human upload, and it's because of the fallibility there, which brings us on to the issue of reliability, which I'm sure we'll touch on at some point. If you can do a lot of the very sort of basic stuff very well, then actually that will give you a huge feed forward in terms of what you're able to do with that data, and the understanding of the patient's disease and how well they respond to treatment, and so on and so forth.
Thank you for that. I quite like it, to use a word, probably it's not appropriate, but it's the non-sexy stuff that ChatGPT might have greatest value for. Christian, your thoughts?
Thank you. Yeah, I think it's really interesting. A lot of the perception around ChatGPT is that it's this, all singing, all dancing model, but it is a kind of first edition large language model that is, the public has had access to. I think it's not going to give you accurate diagnosis at this point in time, but it might reduce errors and it might improve slight, as Alex was saying. I think a lot of the administrative burden for junior doctors especially could be alleviated with tools like ChatGPT, but it goes back to how do we integrate that into the healthcare, EHRs, because a lot of the tools aren't regulated. Anything you put into the OpenAI model, technically, they have access to. So how do you integrate that with clinical records? But I think, if we do integrate it in a way that is safe and, has considerations for ethics and data, then it can be, really useful for clinicians, especially with that, reduction in administrative burden, especially with things like, when you do a ward round, typically that used to take up most of the day, then you do your jobs. Now it's the ward round is, a very small part of your day, and the rest of it is navigating these systems that are very complex, typing up the notes, making sure everything's in order. So I think that could really help things like workforce retention. When clinicians train 6 to 15 years to be a clinician, these tools can really help them focus on why they did that training. I think another thing to consider is the risk of failure. I think if you use these tools in environments like emails to managers, and that's okay in a lot of scenarios, and that's what Microsoft has done when they've integrated it into things like Office, that makes your life a lot easier. But when you're using it in a healthcare setting, the risk of failure is significant. You can't really email, diagnosis to patients that are wrong. You can't order wrong investigations for multiple reasons. So the considerations are a lot more intense with healthcare, and it's how we get that right, and the regulation around it, and interoperability as well.
Thank you for that. I'm conscious of time, and I see some hands coming up. So Rizwan, I don't think you've spoken yet. So Mark, I'm going to be very naughty and go to him first.
Thanks, Alison. I think my my greatest fear is that we're already repeating some of the mistakes of the past, which is that we become fixated on a shiny and we use that as the vehicle rather than going back to it. I very much like Mark's term of brass and muck. A lot of my AI presentations have got the phrase boring AI is good AI, but you know, Prof. Jeffrey Hinton, imaging AI is going to put radiologists out of a job. IBM Watson, what happened to that? And we've got a situation where we now have the current latest shiny, and instead of exploring the value of what it can do, we're maybe flipping that conversation already from the outset on its head. Christian alluded to earlier that, you know, if you don't understand the limitations of it, someone spouting something with confidence will be accepted without realizing you're actually taking untruths. And this was from some of the earlier outputs where it was giving links to papers and research that simply didn't exist. And we take that across. And so perhaps maybe from the outset, the first thing we should do is just accept, guess what, it's a tool, it's a clever tool, but it's a tool and it's a first generation tool. And what are the kind of things it could do, which would be of value to us, rather than us having to find reasons to integrate it into the care we provide, because then safety is an issue. We found that, for example, it can aggregate a whole bunch of data into nice summarized outputs. Well, great, discharge summaries, can it handle those? Can it take in multiple data points, you know, imaging reports, intervention reports, what all the various notes we've got them, and spit those out? That saves our junior doctors a hell of a lot of time from jobs that they can focus on patient care. If it can take unstructured data and provide a structured output, well, that can feed into what we can do with the data going forward in meaningful manners as well. And that can feed into the public health measures of what we can do with these vast lakes of information we have, again, for the betterment of patient care. I suppose a concern, though, it is how do you control the flow of sensitive data from healthcare to commercial organizations? Because clearly, you know, these are trained, you know, large language models are trained on data sets. We're providing them with oodles of more data, and we do need to find where the limitations lie just in that data transfer as well.
Yeah. It did in what you were just saying, this issue of security and privacy that we need to think about when integrating. Chris, I don't think you've spoken yet, and then I'm really conscious of time. So Mark, unless you're burning desire to speak, I'll jump to the next question. So Chris.
Thanks, Alison, and nice to meet you. What are the opportunities of ChatGPT for healthcare? That they're enormous. But we have to walk before we can run with it, and we've got to focus on some potential early wins or early appraisals of the technology to help people gain that understanding, so that they understand the limits as well as the possibilities of the tools. We always have to work in a supervised way with these new technologies in healthcare, as opposed to some other environments where they can perhaps be used in a less supervised, free-flowing, less safety conscious or risk averse way. And I've already heard some key examples, I think, from health records or from a high throughput, you know, kind of high burden manual labor type cognitive tasks like preparation of discharge summaries, or parsing of those discharge summaries to find the action, or converting some of the free text that we all want to provide as humans, but into a more structured format that's then easier to ingest. And we've got a couple of ways that we can do that. So we can run this perhaps within deployment of Microsoft tools, where we then know that the input is not going back, it's protected, it's staying within the healthcare data environment. Where there are clinicians, it's working as a co-pilot rather than semi-autonomously. And there's a nice piece, that one example that I've seen, where it asked ChatGPT to scribe a clinical consultation and provide a note of it. And then it asked ChatGPT to review that note and find the errors in that note. So a double layer of AI before then the human had to provide some additional sense checking and already work within that structure as well. There's a potentially an early, safer, interesting productivity hack for healthcare.
Thank you for that. That's a useful aspect of ChatGPT. If you get it to do one task and then you ask it to do it again or correct itself, it does attempt to do that one. I'm going to jump to the next question, but Mark, you can maybe link back to what you might have heard already. So I shall come to you first. So the next question was, how can ChatGPT and large language models democratize access to healthcare and reduce inequalities? And I'm quite interested in this one. I'm waiting to hear a key word called bias jump in. So
Yeah.
Mark, I'll do you first.
Yeah, if you like. I mean, it's really early days, so all of us are doing is hypothesizing. But my initial hypothesis would be that inequalities would probably get worse, as opposed to better, and a democratization, as you called it. If you take free Libra patches for diabetics, I would, and I haven't finished the research yet, but I would make a bet that more middle class people have got them than working class people, because they know what they're called, and then they vote for Theresa May, and they read the papers and talk about these things, and they bully the GP into one and moan about postcode lotteries and so on. So I think the bigger risk is that inequalities will get worse, as they've done since Blair was in government, actually, and house prices and everything else that kind of went with that. So I would worry that that will get worse. There's a lot of evidence of the elective recovery being biased towards non-BAME communities, against travellers, against people with learning difficulties, and so on and so on and so on. So all of these benefits everyone's talking about are not going to be at the fingertips of someone who lives on a traveller site, or someone who's blind or hasn't got fingers, and so on. So I would kind of worry about that. But we're right at the early stages of it. Yeah, absolutely, it will democratise the worried well, and they can have slightly more interesting conversations with their GP, but that's not going to solve inequality. So I would kind of posit that things are likely to get worse unless there's positive discrimination, which is quite interesting. So there's a trust in the Midlands who positively discriminated within their RTT waiting list. So as you entered the waiting list, if you were black or disabled or old or poor or something, you got a higher weight and you got higher up the waiting list, which won a patient safety award but failed the Daily Mail test. So make of that kind of what you will.
Yeah, I think we're dealing with a lot of it. It's not just ChatGPT, it's digital exclusion. It's the wider arena there. Yeah. Rizwan, you have your hand up.
It was just to give almost the counterpoint to agree with Mark about the democratization. I think it will make it worse. I just touching to Chris's point, actually, from the outset, I think the first pass is improving quality assurance. The problem we found is no one wants to underwrite any business cases where you're not actually making any monetary savings. Efficiency and productivity are the key, because someone's going to say, what's my bang for buck? And sadly, no matter all the verbiage we put out, safety doesn't really excite the bean counters and purse string holders. Ultimately, it's a tool, and it's a tool that costs money. And so it's going to be predominantly or initially directed at the people who can afford to pay for it. And if, Mark's given that very elegant example of positive discrimination. Again, if we look back on an example from 2019 in the US, where there was a healthcare organization which used an AI screening tool, which found that because of the data it was translated on, it preferentially enhanced remuneration or escalated the care provided to white patients, and deprecated the care provided to black patients. And so I go back to the same comment I made earlier. ChatGPT, it's a tool. It's in itself can't solve anything. We need to be careful not to give it more importance than perhaps it's due, and provide the structures around it where we can do good with it.
Okay, thank you. I'm going to jump to Chris, and then I'm going to move on to some follow-on questions. So, and I'll try and make sure I get everybody else who hasn't spoken in. Chris.
Yeah, thanks. And it probably just links into the previous bits and goes right against it as well. I think it's right. It's tools within a transformation program, a transformation strategy. You can push back against the challenge of finding some value, finding some ROI, having some shiny by weaving into your implementation evaluation plan all of the other stuff, the brass from muck pieces, as long as you've got something else there which is perhaps higher profile, higher risk, even if that doesn't deliver, you still delivered all the rest of the project activities and have got those wins. Digital transformation, whether it's AI tools assisted or otherwise, yes, there's risk of aggravating inequalities, but there's also significant opportunity. NICE, I think, is mandating EQIAs, up front for any of these projects that are potentially coming forward, which is focusing everyone's minds that's interested in this space. And that's got to be a benefit. And I think we've got some data internally here that if you do that right, then you not only reach the patients from the deprived communities, but actually you even out some of the imbalances and outcomes from the communities within those digitally assisted service pathways. So I think there's hope as well as anxiety, concern around the equality piece with digital.
Thank you. We do have the facility to extend by about 10 minutes if people can stay on because of my late arrival. If you can, I'd really appreciate it because we're getting some interesting insights. Thanks for the thumbs up. I'm going to jump because this idea, it's a tool and it's the boring AI is the good AI, and that facility of the administrative class tasks that it'd be useful for. But of course, what's captured people's imaginations is its use as a medical device and direct to patient care. So the next question, and I'll jump to give you forewarning to yourself, Alex, and then Christian, because you haven't spoken yet, but please do put your hands up for the others. Is the consequence of classification of ChatGPT as a medical device, and your thoughts on that. So Christian, I'm going to go to you first.
Sure. So I think it comes down to, it has to be a medical device when it's making a clinical decision. And again, it goes back to what are we asking ChatGPT to do? I think in certain scenarios, if you're aware of the constraints of the model and the limitations and the potential hallucinations that can come out of ChatGPT, then, I think the initial use cases are experimentation around how we can use it in things like diagnostics. But I think for anything in terms of medical devices for clinical decision tools, it would have to be a specialized model that is made specifically with, data that you know what data you've put in and what data you're getting out and what data is being referenced to come to that conclusion. Because it's great that these large language models have billions of parameters, but that's not necessarily a good thing when you think about a diagnostic tool, because you want to query where that data is coming from. You want to make sure it's all valid data, it's relevant. And it goes back to before what we were saying about inequalities. It's like the melanoma tool that was recently used, and it was mostly trained on white skin. So how can you say that data is representative? And unless we understand what the data is, which might be difficult when you do think of these models that have billions of parameters. But it is really important to understand. And when it comes to a time where there's a lot of FDA 510K medical devices that are essentially black box tools, that it's just ethical that we understand what data's gone in, whether it's representative. But I think in the meantime, we're not there yet. It's not an AGI. It's a large language model. It's good at certain things and certain tasks, and I think productivity is a big one. But I think we just need to be careful about what kind of what we extrapolate from the use cases.
Thank you. Alex, or is it Alexander? Some people don't like being shortened.
Well, I prefer Alexander, but I don't tend to lose sleep over it, so I won't be offended. So I think that Christian makes a good point, particularly when he references the specific roles that often you need a device to take on. Certainly at present, whether one device could then perform multiple roles simultaneously is perhaps another matter, but equally it's going to need to be validated for each of those. And perhaps if I can give an example of a non-ChatGPT medical device, the one that I've been running my clinical trial of is something called GI Genius. And what that does is that detects polyps during a colonoscopy. Now, humans detect polyps during colonoscopies. The AI device watches the colonoscopy as it's happening and in real time tries to help you spot more polyps that you might not otherwise see. And that raises all of those issues that we've just talked about, because it is being done for a specific task and it's been validated for that. So that's fine, technically validated. And my trial, the purpose of it is to demonstrate what happens when you put it into routine practice. So, or when you introduce it into a system with all the fallibilities of the humans that are operating it and the way the actual broader system functions. But if we come back to the issue of clinician oversight, it's something that the clinician has to use in real time. It's not something that can operate independently, because it will generate false positives. We know that it does. And so it relies on you as the clinician looking at what it's identified and saying, yes, I agree, that's an abnormality, that's a polyp, I'll take it off, or actually, no, I think that's just nonsense, I'll ignore that. And subsequently, you then got the issue of bias. Well, the humans have the biases as well as the potential for the devices. So thinking about device-based biases first and the data, if you imagine that you train one of these, they're convolutional neural networks that they're based on. If you train this AI device using images of polyps from white 56 to 74-year-olds in the UK National Bowel Cancer Screening Programme, then you will get a subset of polyps that it's very good at recognising. But what about the sorts of abnormalities you get in everybody else? Now, this is a long way off in terms of thinking about data sharing and information governance and so on and so forth, so I won't go into it in too much detail, but imagine if you've got a device that's linked up to a central network that can send a central server that could send anonymized data from your colonoscopy and all of the polyps that have been recognized, so that can then learn in real time and then share that learning back to the device in real time rather than relying on periodic manual updates. If you can do that internationally, then regardless of who you are and where you are in the world, you could get the same benefit from AI in your colonoscopy as anyone else. But if you don't, then you could be looking for the wrong type of polyp in the wrong person, and you might not see it, which could lead to a missed cancer. So there's that bias.
Thank you.
Very, very briefly, the bias the other way is human biases. When we know there is data that says that humans get tired when they do colonoscopy and they miss more polyps later in the day than they do first thing in the morning. So you've got the opportunity, and then that's just a very, very simple thing. It's not always about bias, it's kind of human capability, if you like, but it shows that we have an opportunity to overcome some of the human limitations. And then, of course, you do have issues around who gets to regulate how that bias is challenged. Does the device do it automatically? If in a different context, does it override when it thinks a human does something wrong or is subject to bias? Or does it just present us with more data and more opportunity to help us review our own decisions and assess the quality of our own decisions?
It is the regulatory field for this and liability as well. It is quite a complex question to answer. Christian, you put your hand back up again, and then I'm going to sort of jump to the next question after that. But I would really want to push this idea of, as a medical device question. So Christian, back to you.
Yeah, just a quick point on these medical devices. I think one of the most advanced examples in the UK is the Brainomics stroke detection protocol. And I think that has raised some really interesting questions around, when these models are so good and they predict the need for things like thrombolysis, is it negligent not to use it when we know that, in certain cases it's actually been better than humans? And these are huge decisions for thrombolysis, which have implications for bleeding risk and outcomes. So when you've got an MDT of neuroradiologist thinking one thing and a model thinking another thing, again, it comes down to this validation. It's really difficult, and there's a lag period with PhDs looking into validation of these tools. But I think that's just a really interesting consideration of when do we not use it, and is it negligent not to use it?
I will just very cheekily jump in on that example, because what there is often lacking, particularly when you go along the clinical pathway, is feedback loops. So I've been on site where I've watched these, and there has been a disagreement between the radiologist and the tool. And so, well, who was right? And they don't know. I could possibly, if I had time, find out what the final clinical outcome was, but I haven't got time because we're getting hundreds of that, and that lack of that feedback loop has huge implications for, you know, automation bias and de-skilling and so on. So that's quite an interesting one. Alex, really briefly, because I want to get through all the questions and I want to let the other speakers jump in. Oh, you're on mute. You take the trophy from me.
Sorry. So just picking up on the issue of whether it's ethical to not use something that we know can outperform humans. I, like Mark, put into ChatGPT some of the questions just to see what it would come up with, and it said that it should offer patients the opportunity to decide whether AI is used in their care. And I found that a really interesting point, and perhaps to comment that typically the responsibility for deciding will lie with the clinician, because these are medical tools in these cases. But how much do we extend the ability for patients to decide what is and isn't used in their care? I won't comment further, but just really an interesting question, I think.
That raises GDPR Article 22, right? Not to be solely, you know, subject to an automated decision. So, you know, this idea, so that raises those questions. Right, Mark, I haven't heard from you for a while, so I'm going to give you the next question, which is, and you may have addressed this in the first question actually, is what are the challenges for the future healthcare workforce?
You know, well, I could say I answered that before you joined the call, but I didn't fully. I made a related point, which I think is the conditions for AI, and one of the biggest ones of those is workforce. So the kind of the anecdote I gave was that we're a kind of a big but provincial trust, so we're working more closely with London teaching hospitals, which have got more roles around kind of research and the use of AI and so on. So I think one of the implications for workforce is, and it links to the point Alexander was making about kind of learning in real time internationally, which is really, really interesting, is people proactively sharing their work in a new kind of workforce. So the Goldacre review that came out, it all talks about, you know, usual stuff about open source, but one of the key points it makes, which I think is really interesting, is the responsibility to proactively share something that you're doing that's good. And again, that talks to Christian's point about, is it negligent to not use the AI for something? So I think for the future workforce, there is something about, and it would completely unpick the whole academic research model, because the whole point is that you will compete for research funding and race to publish papers first. So the future workforce, academic and clinical, is much, much more about proactive sharing, as opposed to being the person who invents something, makes some money off it, writes a paper about it, gets a professorship because they've done something really clever. So I think that's really interesting for that kind of for sort of the senior workforce. I think at the level, what I'm hoping, so one of the things I talk about a lot at conferences is the kind of analytical workforce. And what we hope, the big promise is that we automate away all the crap that we have to do, which is sending sit reps, producing board reports, patient tracking lists, and we could actually concentrate on drawing the graph and understanding the graph and going and talk to people about why ED fell over last night, or why Christian's HSMR is higher than Alexander's, or whatever. So I think if I was trying to be positive, as Chris was earlier, I'd say there's some really interesting opportunities for the workforce, because we'll automate away the drier work so that they can concentrate on the more complicated work. That would certainly work in clinical coding. So I think I can automate away the coding of chemotherapy, endoscopies, simple stuff, and hopefully let my coders do more interesting work and do, you know, a heart procedure that took all day, and go and talk to the cardiologists about it. So I'll try and be positive and say that it would automate away some drudgery and let us do more interesting kind of analytics. But I think the proactive sharing thing is quite interesting because that's quite different for people.
Okay, that links with, actually, I've got 3 remaining questions, so I'm going to grab one slightly out of order and jump to Chris, because you mentioned him, and linking onto this idea of this proactive approach that you want is, how can the healthcare system be proactive in their approach to this revolutionary tech? So we've talked a little bit about being a little bit careful and not giving into the hype. Rizwan mentioned that, Chris, but how can we be proactive in utilising this tech?
We've got to use some of the hype. We've got to hitchhike a little bit on that as well. We've got to get people excited. Listen, the workforce, clinical, you know, and all of our other colleagues, you know, across healthcare is ground down, is broken, and it needs some hope. It needs some light, and it needs to see some way to deal with the kind of mounting amount of work that there is coming our way, given the shape, size, age of our population, and the healthcare demands and social care demands that there are. So I think we've got to see ways that it can be fun. I think you've got to see ways that it can make people's lives better, because that's why most people are in healthcare. There's a motivation to improve the health, you know, the life of others, but also their own life needs to be needs to be fun, and needs to be time, and needs to be balanced, and that's where the opportunity. So I think there's some messaging to sell there. We've got to take people along with us and help them understand how to use these tools, and I like the idea of using the tools to help us understand how to use the tools. So where can language models you know, help us get some information about what the opportunities, the risks, to help people get that reassurance, that familiarity with them. And we're bringing in some things like the collaborative working, like the knowledge sharing, like the breaking down of some of the data tangles that's going to come along with that. And we're using user-centric co-design. So we've got to, you know, what do people need in their hands? How can they use it? The AI doesn't have to be that complicated, but if you need to dive in behind it and understand which patient population went into creating this model output and so on is there, it's layered there, and within good quality software.
Yeah. Thank you for that. I quite like the idea of using the hype. We can be a bit overly cynical the other way, can't we? Going, oh, think about the risks and be careful, don't give down the hype. But actually, there is some positives in that. Rizwan, a couple of the questions. These are a bit sort of more sort of from a regulatory point of view, sort of technical concerns. And please do, Chris, you might have a comment with that, but please do put your hands up, everybody else, in the last few minutes. What are the important considerations around patient data security and regulations? So we've touched on that a couple of times in this chat. So Rizwan, do you have any sort of further comments on that, or anybody else?
I think we have covered that previously, but it goes back to the point Christy made as well, which I agree with wholeheartedly. Regulatory compliance costs, and you can understand why companies are quite keen to try and sidestep classing these medical devices so they don't have to jump through those hoops. But actually, if we want to use the hype, we have to also be very clear of what not just the limitations, but what the capabilities are. And to allow access to some of the more broader features of it, we do need to demonstrate it's safe. And once we do, then we really can liberate people to use them in more innovative and exciting ways, whereas right now, you know, they will be constrained by some of the concerns about data usage and patient usage. If we're focusing on patients for an example, I think that part of the using the hype and how we can make it safe would be to be a bit more granular in what some of the benefits and uses are. One, as a broad principle, using technology more judiciously will actually allow healthcare workers to be more human. It frees up time to actually engage in bedside care and away from the computer screens that we're having to do right now. It can also, for example, convert the language of what we put in notes, in reports, into forms which patients and the lay public can understand more carefully. You know, there's been a lot of talk about, for example, making discharge letters instead of writing to GPs. You write to the patient and copy the GP and another way around. And in principle, that's fine. But, you know, we do use technical terms, and it's how can, instead of asking us to pause even further to how can we rebadger, well, then offload some of these tasks. We say what we say, we allow ChatGPT to convert that into a patient-friendly format. Of course, you have to make sure that the patient-friendly format is true and you know, reasonable, in line with what you've said in the first place. But doing all these things means that we're not having to focus more and more on the administration burden, and we can focus on patient care to make it safer from them alone. And that in itself is a different form of regulation. And from the point of view of the healthcare service in general, I think the fact that it exists is going to be a boon given what's going on right now. And again, people are leaving the healthcare space to go into things like the AI and health tech sector. Well, perhaps this may encourage them, you don't need to leave, because we're using it more in a innovative and a safe manner within the healthcare service as well, and provide those opportunities for them.
Fantastic. Chris, you put your hand up, so not only do you get to respond to that, but you also get the last question thrown at you, so you have to try and incorporate it into what you're saying, because the very last question I have, which again I think we've touched on, is how can we moderate content with such large data sets and parameters, which I think Christian commented on a little bit earlier on. So please do feel respond to what you've just heard, and maybe touch on that.
I was did a language model to help me remember all the bits I was going to kind of weave together, and I've not got to weave together as well with that too. Please prep me my answer. Type furiously. I've been blown away by the discussions when we've taken forward the propositions with AI to patient groups, individually and broadly. Bring it on was pretty much the take-home summary from some of our user experience work. Not all patients, but many patients are ready for this, and if we can build in something of an opt-out or a kind of consent piece or an explainer piece, perhaps facilitated by the language models. I like the idea of converting the medical language to a more layperson, patient-friendly with a format with a sense check on it. Then I think we can potentially crack this and help patients understand that it's going to make healthcare better for them, more sustainable for the workforce, and so on and so forth. So that was kind of my kind of comeback, was just a bit of local experience backing up Rizwan's points. Can you remind me what the last question was?
It was a more technical thing of how can we moderate content with such large data sets and parameters? Sure.
There's regulatory considerations around that, and like the education of the workforce regulators, are just sort of struggling to kind of keep up with the pace of change, and within this as well. So that's going to hold some of that back. And also I think you talked a little bit that it's difficult to get the model kind of calibration, because it doesn't get the feedback loop piece of that as well, because it's locked in, it's in place. So I think we've already developed some examples where the AI is constrained like that, where we're testing the waters, where we're finding out where the challenges, we're de-risking some of those aspects with that as well. So focusing in on a narrow use case, or focusing in on a model which is fixed, and where we understand the training and validation that's gone into its deployment as well. The large language models present us big different problems with that, but I think we can find ways, some examples we've heard about health records and others, where we can test the waters a bit further of that before we open up the whole space.
Okay, Christian, final word before I sum up. I have to think of 3 takeaways. I can think of loads. It's been a fantastic conversation. So Christian, final word.
Yeah, just briefly on the regulatory issues, you know, it will ultimately come down to that with things like medical devices and tools that we can use in practice. But, you know, we're already seeing the burden of over-regulation. It can actually be a barrier to innovation. So, for example, with Google's BARD tool, you know, that it's not available in Europe. It's available in the UK and US. So and ChatGPT, for example, is banned in Italy. So you can already see where there's constraints on you know, things like accessibility to these, you know, open source tools. And I think, you know, it begs the other question with workforce. You know, are the regulatory bodies ready for the you know, the thousands of AI tools that are about to be submitted and over the next few years? And how do we understand that, you know, ethically? There's philosophical considerations. So I think it's interesting, but it'll likely evolve over the next few years as fast as AI is.
Thank you. You're touching on my job there, so I will respond, be cheeky and say, well, you know, regulation can also stimulate innovation because it can make sure you get the right type of innovation, and that we don't rush to use these tools before they're actually ready to be used safely and fairly and ethically. So it's about balance, I think, with that one. And I'm not going to comment on whether the regulators have got the staffing. It's a difficult sort of field at the moment with funding cuts and so on. So thank you for that. So I'm not going to keep you any longer. I just want to sum up. I was quite surprised at some of the answers, really, in that there was a strong feeling that it wasn't necessarily to democratize healthcare or deal with health inequalities. And there was some conscious, acknowledgement of the fact that there are biases involved and that would need to be very specifically addressed. But I think that is the wider issue of digital exclusion. So it's not a quick fix to deal with inequalities. Dealing with workforce, we've talked about training, but also helping with retention. But I think a key finding is, if we can think of these sort of non-sexy use cases for these tools to help deal with the administrative burden on staff, that will actually help retention. It will help staff to do the more human work, which is the more valuable work. That was really, really important. With regards to regulation, I think I'm in agreement with you, Christian. It is more complex around it, and then the decision making and the liabilities as well, that gets involved in there. And there's a lot of thinking that needs to go into there, and we're in the early stages of that. And I think that's why sometimes a little bit of a pause, such as Italy have done, might be the founding on that one. But I think I really also like the idea of just getting the patient voice in on this, and the patient requests and the user requests, and the this idea of opt-outs, the idea of converting to medical and lay medical language to lay language, and giving more ownership to patients themselves, which sort of matches the concern that we have with patient privacy of their data and where that's going, and that running to that one. So again, there's positives there, and I think that came out of this talk, which was really, really fantastic. And so it's about balancing the hype, taking calming down where it's going a little bit too much, but taking some of the some of the hype and using it for right, understanding the risks. And I think there's a lot of potential, and I was quite interested to find out that there's already work going on in that field. So a lot more positive discussion than I was sort of expecting. So thank you ever so much for your time. I do apologize ever so much for my lateness. I've tried on 2 different computers and 2 different operating systems and all sorts, and I got there eventually. So thank you for your time.
Thanks so much, Alison, for moderating that. Thanks to all of our speakers. Once the report is written, we'll share that out for you all to see, just to make sure everyone is okay with what's in there. So if you'd be able to review that once it comes your way, and then we can share some of this out towards the community. We're looking to set up regular discussions like this so we can keep the conversation going, and it's not just restricted to live conferences. So look out for more invites coming your way soon. But thank you all for your participation.
Can I be really, really cheeky and jump in? Because I didn't get to introduce myself properly. That I work for, well, it was called a multi-agency advisory service with MHRA, CQC, NICE and HRA. And this is exactly what we're looking at. And we are doing an awful lot of work on how we regulate these new technologies. We called it the AI Digital Regulation Service within the health, and we've got a website. Please reach out and contact with me, and please do feel free, because we're really interested in hearing your voices and learning. I'm very much wanting to do ground up, not top down from the regulators telling you what you should think. I want you to tell us what we should be thinking, but don't tell anybody I said that, and hope the recording stopped. Yeah.
Perfect. Thanks so much, Alison.
Thank you. Take care, everyone.
Fantastic. Thanks so much.
Super.
Thanks, everyone.
Thanks all.
Bye.
Thank you.
Bye-bye.